So for a decade, we only had one drug that had been proven to be effective in liver cancer, and that was sorafenib. Sorafenib was a big breakthrough in the management of liver cancer. We never had phase 3 data that showed that a systemic treatment could improve survival, and it did that successfully with a hazard ratio of 0.69 or a 31% decrease in the risk of death. Interestingly, it extended survival without inducing real responses. It was very uncommon to get a response. It really improved survival by slowing progression, and the drug has a very clear safety profile, typically hand-foot skin reaction, GI toxicity, anorexia, diarrhea, fatigue, generally things that can be managed. And in this population of patients who have underlying liver disease, it was tolerable, right? It was not like other small molecules that had failed in liver cancer because of toxicity or chemotherapy, which carried toxicity. It was the right drug for the right disease. Given it had no responses, the median survival benefit was about 3 months over placebo. The feeling was, well, this would be very easy to beat, right? And this would usher in the new generation of all of these molecules in liver cancer. And as it turns out, that was not the case. We had numerous failures, and still to this day, nothing has beaten sorafenib. Nothing has been shown to be better than sorafenib at improving survival. But we do have other drugs available for liver cancer, and in the frontline setting, there is one, specifically lenvatinib, which was approved about 2 years ago now. And lenvatinib is a small molecule inhibitor of several kinases like sorafenib. It does hit the VEGF receptor, but it also has very potent activity against the fibroblast growth factor receptor. And the FGFR family is very important in angiogenesis and resistance to VEGF targeting, and also in liver cancer itself as a proliferative driver. And early studies showed in single-arm studies that lenvatinib had some activity in liver cancer, and that led to the REFLECT study, which was a large global phase 3 study, open label, of lenvatinib versus sorafenib. It accrued over 950 patients. And its primary endpoint was non-inferiority, to show that lenvatinib was non-inferior to sorafenib. And what that means is it doesn't mean they're equivalent, but it means it's not significantly worse. And if it meant non-inferiority, then they would try to prove superiority. And there were secondary endpoints like PFS, TTP, safety. And that study was a positive study. It did meet its non-inferiority endpoint. Survival with sorafenib was about 12.3 months, and with lenvatinib it was about 13.5 months. But that was a hazard ratio of 1.06, which met its non-inferiority endpoint. What was striking between the two arms of the study is response rates. For the first time, we had a drug approved in frontline that had a single agent response rate that was higher than sorafenib, right? So sorafenib, by what we call modified RECIST criteria, which is the criteria where you not only measure the size of the tumor, but the enhancing component of the liver tumor, because liver tumors have a very characteristic enhancement. And we saw with sorafenib that was around 9-10%, and with lenvatinib that was just under 20% by investigator assessment, or about 20%, I should say. So that was very striking, right? But still, we did not see that even though it had a higher response rate, that overall survival was significantly different. But what we did see recently in a sub-analysis is that with either drug, if you respond, you tend to live longer than if you don't respond. And so for the first time, we're starting to see data that if you can induce a response with a drug, regardless of the drug, that you might live longer with liver cancer, and that's a new finding. Lenvatinib did improve progression-free survival. It also improved time to progression. So again, things that are surrogate endpoints, response, TTP, PFS, but still OS was the same. There were some unique characteristics of the study. Lenvatinib is dosed by weight, whether patients get 12 or 8 milligrams, whether they're 60 kilos is the cutoff. If they're heavier, they get the higher dose. Also, the REFLECT study excluded patients who had main portal vein invasion. That's not something that has been done in other sorafenib studies. And that might explain this longer survival of 12 months with sorafenib. Now, toxicity is different between the two drugs. I mean, lenvatinib is a very potent VEGF inhibitor, and we see a little more hypertension and proteinuria, both effects of targeting the VEGF axis, and these need to be watched for. Both drugs can have GI toxicities, like diarrhea, and sorafenib, though, has a higher frequency of hand-foot skin reaction. So these are all important differentiators, and for patients I'm seeing in clinic who are Child-Pugh A, who are appropriate candidates for systemic treatment, if they have bulkier tumors or they need a response versus just stable disease, those are patients I'm tending to go with lenvatinib frontline instead of sorafenib.